Hello everyone, my name is Dr. Chandan Narang. I have done my fellowship in foot and ankle surgery, and today we will deal with the bimalleolar equivalent fracture. I will tell you what are the points you need to see, what are the typical findings you need to see on the X-ray, and how to avoid the missing out of the deltoid ligamentous injury, how to do the external rotation test inside the operation theater, and is the cotton test that for the syndesmotic injury, is it really useful? I'll cover up those. Stay with me. I'll show you one X-ray, and you have to identify what are the possible injuries here. Just pause this video and just look at this X-ray. This X-ray is showing number 1, the lateral malleolar type B fracture. Number 2, the talus is shifted along with the distal part of the fibula laterally. Number 3, the syndesmotic injury. As you can see with the white arrows, the syndesmotic widening has occurred. And the last thing is, if you look at the medial clear space, this space is between the medial aspect of the talus and your medial malleolar lateral surface. This space is increased and it is definitely more than 4 mm. So this fracture condition is known as bimalleolar equivalent fracture. It is not bimalleolar port fracture. Why so? Because the medial malleoli is intact here. It is a variant of BMP, the bimalleolar port fracture. Here the deltoid ligament is injured instead of it, or we can say it is ruptured instead of your middle malleolar fracture. So what is the mechanism of injury? In such cases, it is a supination external rotation. It is a SCR type of injury. I'll show you a video, demonstrate a video how the talus rotation will lead to the fracture of the fibula, the separation of the tibia fibula at the syndesmotic level due to rupture of the AITFL, PITFL, and this increase in the medial clear space. I'll show you a video so that you will be able to understand how this is a supination external rotation injury. So just focus on this video. There is a talus, there is a mortise, there is a fibula, and the yellow shaded part, it is your AITFL, or you can consider it a PITFL as well. Here will occur the rotation of the talus. With the rotation, you notice that part got ruptured, the yellow shaded part got ruptured, that is known as AITFL. The fibula pushed laterally and simultaneously upward. So there occur rotation, it is laterally and it rotated upwardly. So and simultaneously the medial clear space also increased. I'll tell you why the medial clear space increased in such injury. One is due to syndesmotic injury, second it is due to the shifting of the talus. How shifting of the talus will increase the middle clear space? Because the talus is attached to the distal part of the fibula with the help of ATFL ligament, that's the anterior talofibular ligament. When this fractured part rotates and translates laterally, this talus also moves along with it, and because of this there occurs strain on the medial ligaments of the ankle that we know as deltoid ligament. So that's why the deltoid ligament gets ruptured in such cases. Just look at this X-ray. What are the findings we can make out? Number 1, look at the fibula. It is fractured. It is kind of an undisplaced fracture. Second, there is an increase in the medial clear space. So what are the possibility? Either there is a syndesmotic injury, number 1, or either there is a deltoid injury. These two things you have to keep in mind when you see such kind of a picture. So what was done in such case? The guy fixed the fibula only After fixing the fibula, he might have thought, okay, I'll decide intraoperatively whether there is a syndesmotic injury or not. So what he did, what he might have done, they fixed the fibula. Okay, he tried to do the cotton test. It is insignificant. The cotton test findings are insignificant actually. You cannot assess properly. So we can say that that's a subjective finding. So he looked at the X-ray and he find it good reduction. The syndesmosis looks good. The medial clear space is equal to the tibiotalar space, so it looks good. But the patient still complains of pain in the ankle even after 6 months of this surgery. Plus, he also complains of instability while walking. There are few number of patients, but these patients number are significant. So what he did, he removed the implant. Might be thinking the implant is causing the impingement, so he removed the implant. But after removing the implant, the patient complaint are still there. He is still complaining of giving away. So when the stress test was performed, it was found that the medial clear space is increased. It is more than the tibiotalar space, and when we compare these two spaces, if one space is more than 1 mm as compared to the other, then this finding is significant. That means the deltoid ligament is ruptured here, it is missed. So what we'll do in such case? In such case, we have to clear up the medial gutter. Number one, we have to open up the medial gutter, we have to clear it up, and we have to repair with the help of suture anchor. Let's look at the next case. This is a Weber type C fracture. The talus, look at the talus and look at the fibula, distal part of the fibula. This talus and the distal part of the fibula, they are laterally translated because the talus is attached to the distal part of the fibula with the help of ATFL, that's the lateral ankle ligament. So when we fix the fibula, so the talus as well as this fibula translate medially. Okay, so there will be reduction in the medial clear space. Second thing, if there is a syndesmotic injury, also, if we fix the syndesmotic injury, it seems after doing the syndesmotic reduction and fixing it with the screw, your X-ray will look normal. If you look at this mortise, ankle mortise, it looks normal to me in the second image. After fixing the fibula, after fixing the syndesmosis, the medial clear space and the tibiotalar space, and if you look at the space between the this distal part of the fibula and the talus, it looks also normal. So this was normal, but this patient still complains of pain in the middle aspect of the ankle, complains of giving away of the ankle, and he complains of pain while coming downstairs, especially. In this case, the surgeon he removed the implant thinking it might get relieve the pain. But when he came to us, we did the external rotation stress test, and what was found, there is increase in the middle clear space. So the deltoid ligament injury was missed in this case also. So what will happen if this medial clear space increases? What are the consequences? Number one, the giving away of the ankle, the medial ankle instability. There will be a problem while coming downstairs. When the patient comes downstairs, he will be having pain. And what are the other things? It can lead to, due to increase in the medial clear space, the tibio-talar contact area, it changes. And with 1 mm translation, this tibio-talar contact area changes by means of 43%, and the contact pressure, it is increased by 30%. And this data suggests that it will lead to early osteoarthritic changes. Though the cartilage of the ankle is very much resistant, it is different from the cartilage we are having in the knee. So you will hear about the knee osteoarthritis very commonly, knee replacement. That's why there are happening a lot of knee replacement. But ankle arthritis, you will hear very rarely in the very old age. If you see very few cases, if it is happening, or otherwise it is due to secondary causes. The primary osteoarthritis of the ankle is the rarest entity, we can say that. Or in case of secondary osteoarthritis of the ankle, the most common cause is post-traumatic. Post-traumatic. So these are the kind of cases where the, for example, deltoid ligament injuries are missed. In such cases, we predispose the patient to the ankle arthritis if we don't do the external rotation stress test or simply the talar tilt test. After fixing all everything, if we do this, we can avoid the injury. So, how do we approach? As I have already told you, number one, we'll fix the fibula first. Second, we'll check the syndesmosis. If it is moving with the external rotation, then we will fix the syndesmosis with the help of screw or with the help of loop, or whatever you, the way you feel good, with the like 3 screws, 2 screws, whichever the way you are comfortable, all are good. After fixing the syndesmosis, we have to do the external rotation stress test again, or we have to do the talar tilt test. Better to do the talar tilt. If there is a deltoid injury, the talar will this talus, superior surface of the talus will show the tilting. Definitely you will see increase in the medial clear space. This is a demonstration. Just look at the fibula fracture, the syndesmosis and the talus. What happened? We reduced the fibula, along with that talus also got moved because it is attached to the fibula by means of ATFL. Okay, but still the medial clear space is increased and the syndesmotic space is increased. So now we reduce the syndesmosis. Suppose it is reduced with the help of screw. So this picture looks normal to me. The motor looks very much normal. If we do the external rotation stress test in such cases, or we do the talar tilt test in such cases, we will see the joint widening and there is a talar tilt. So this is how you should do. Fix the fibula first, do the tightrope for the syndesmosis, and then do the talar tilting. If you see the talar tilt, what do we have to do? We have to fix it with the suture anchor. We have to repair this deltoid. So thank you all.